So I'll focus on the pharmacological treatment of high blood pressure, but it's very important to say that both things need to go together, modifying lifestyle and diet, but also uh, and modifying and upscalating quickly the pharmacological treatment. And I'll explain why is that. Uh, Number one, we're dealing with probably the most important problem in terms of public health globally. The prevalence of hypertension is around 30%. It's not different here in the UK. And currently, we have 1.3 billion people around the world with hypertension. It's the same size as China or India. So it's a major problem. And besides that, hypertension represents the number one risk factor for premature deaths globally. 10.8 million deaths globally are attributed to hypertension. It accounts for about half of all heart disease and stroke-related deaths worldwide. So big problem. And actually, despite the fact that we classify patients into having hypertension or not, the problem is a bit worse than that, because the risk of uh, elevated blood pressure and major cardiovascular events, heart failure, and dementia, and kidney disease, is what we call in clinical epidemiology log linear. That means the risk is proportional. There's no threshold. The higher your systolic or diastolic blood pressure, the higher the risk of patient-important outcomes. So when I say the risk is proportional, I mean that when you go from, for example, 110 millimeters of mercury of systolic blood pressure to 120, your risk of dying due to ischemic heart disease, for example, due to myocardial infarction, increases by 14%. When you go from 120 to 130, it increases 14%. If I change the graph here to mortality due to cerebrovascular disease, mortality due to stroke, if I go from 110 to 120, your risk will increase 18%. If I go from 120 to 130, 18%. So it's always proportional. The higher the levels, the higher the risk. And the same holds true for dementia and cognitive decline, chronic kidney disease, and heart failure. And that's also true for men and women of all ages, and also for diastolic blood pressure. But that's evidence coming from 1 million adults in 61 prospective population-based cohort studies. So what about large-scale randomized trial evidence? And probably that's the most important one. The SPRINT trial, funded by the NIH, conducted in the US a couple of years ago. In this trial, patients of elevated cardiovascular risk were randomly assigned to a blood pressure target, based on a systolic blood pressure target less than 120, versus a standard systolic blood pressure target of less than 140 millimeters of mercury. The investigators enrolled around 9,300 patients, and the primary composite endpoint was a composite of cardiovascular mortality, non-fatal stroke, non-fatal MI, unstable angina, or hospitalization for heart failure. The trial was published at the New England Journal of Medicine in 2015. The investigators were able to create more or less a 13 millimeters of mercury difference in systolic blood pressure between the intensive group and the standard group. Usually the intensive group used on average 3 classes of antihypertensives, and the standard group used around 2 classes of blood pressure lowering drugs. And that difference over time in 3.2 years translated in a 20% relative risk reduction of major cardiovascular events, and with a very narrow confidence interval and an NNT of only 61. Interestingly enough, there was a 33% in the risk of hospitalizations due to heart failure, and a 43% decrease in the risk of death to cardiovascular causes. There was also a 27% reduction in the risk of all-cause mortality. In the trial, the SMB of the trial, the Data Safety Monitoring Board, recommended that the trial to be stopped early for benefit. But even at the extended follow-up, these events were sustained. So it's quite a powerful result. There are very few interventions that are capable of reducing death due to cardiovascular causes in 43% and currently major cardiovascular events in 25%. So that means that exactly what was predicted in terms of the observational studies were also confirmed by randomized evidence. So exactly the same results between observational studies and randomized studies. There are other two studies conducted in China, the SPRINT trial and the STEPS trial, that reach exactly the same result, a 25% more or less reduction in major cardiovascular events. So very compelling evidence and quite easy to implement in clinical practice because it just requires escalation of therapy in a more proactive manner. And I'll get back to that in a minute. Two important populations were excluded from the SPRINT trial. One was the diabetic population, the reason being because the NIH was also conducting a trial called ACCORD in patients with diabetes. There are a couple of differences between the trials, the most important one being the results. There was the investigators in the ACCORD trial tested exactly the same question in high-risk patients with type 2 diabetes. And they were also able to reach a 14 millimeters of mercury difference between groups. But interestingly enough, there was no difference in the ACCORD trial in the primary outcome of 3-point MACE of cardiovascular mortality, non-fatal MI, or non-fatal stroke, which is slightly different from the 5-point MACE outcome that I just presented for SPRINT. And there are several reasons trying to understand why the results are different. Of course, all patients in ACCORD were diabetic patients. There were non-diabetic. All patients in SPRINT were non-diabetic, but patients in SPRINT were older, and they had around 15% of their population had previous CKD, and patients were excluded from the ACCORD trial. And this is a population which is particularly sensitive to intensive blood pressure lowering. The design of the ACCORD trial was far more complicated than the SPRINT trial. The ACCORD trial was about half the size of the SPRINT trial, and there are other differences in terms of the type of medication used in the trials. The SPRINT used more thiazide-like diuretics, like chlorthalidone, for which we have more evidence for, and there were more hydrochlorothiazide, a thiazide-like diuretic, in the ACCORD trial. But I think the main explanation for the difference probably has to do with statistical power. The event rates in the ACCORD trial were lower than expected, and in SPRINT was as expected, and there were less. The absolute number of events in the ACCORD trial was also lower than in the SPRINT trial. So the question remains open in terms of diabetic patients, and that's exactly what we're trying to answer with the optimal diabetes trial. This is a trial very similar to ACCORD, but with twice the number of patients and twice the number of events. It is fully recruited. Results will be available next year, 2025. We are including in this trial patients aged 50 years or older with type 2 diabetes and high cardiovascular risk. High cardiovascular risk meaning clinical or subclinical atherothrombotic disease, or an estimated risk of at least 20% of major cardiovascular events, so 2% per year in 10 years. The same goals, less than 120 versus less than 140, the same primary composite endpoint used in SPRINT, cardiovascular mortality, non-fatal stroke, non-fatal MI, non-fatal ACS, which is basically unstable angina, or hospitalization for heart failure. This is an event-driven trial, and we expect to see at least 160 events in the trial. So far, the trial has undergone 2 interim reviews, and the SMB of the trial just asked us to keep going. And we also have a twin trial called Optimal Stroke. So patients with ischemic stroke were also excluded from the SPRINT trial. So there's also a question whether an intensive blood pressure lowering target in patients with a history of ischemic stroke or TIA could also lead to less important clinical events. And this is also the largest trial conducted in this population, about 4,400 patients randomized to the same targets, and once again, the same endpoint. And we expect to observe at least 600 events in this population in about 4 years. Results will probably be available early 2026. So it's a 14,000 program, which is ongoing. It's an academic-led trial, primarily conducted in Brazil, where I'm originally from. So blood pressure targets, in my view, should be lower. And the other thing, in order to achieve that, but even to achieve the more traditional blood pressure targets, there are a couple of barriers. And probably the two most important barriers are, number one, patient adherence, as I'm sure you are well aware of, but also therapeutic inertia. So failure to up-escalate therapy if you're not on target. And single pill combinations are probably are efficient and effective ways of fighting back low patient adherence and also treatment inertia. It's far more efficient, and this is coming from a meta-analysis of around 150 studies published in the BMJ a couple of years ago by Law and Wald here from London, where they compare the effects that you will obtain by starting treatment with 3 drugs at half dose as compared to starting treatment with 1 drug at standard dose. And as you can see, both in terms of systolic blood pressure, diastolic blood pressure, but also in terms of reducing the risk of fatal events due to coronary artery disease or stroke, it's far more efficient to put patients on target if you start treatment with 3 drugs at a half standard dose. The difference that you will obtain in terms of systolic and diastolic blood pressure difference will be greater, and that will translate into less risk of coronary artery disease mortality and cerebrovascular disease mortality without a trade-off of increasing the risk of side effects. Usually, when you treat patients with monotherapy, you only be able to control about 25 or even 30% at max of patients. If you use 2 drugs, you'll probably just be able to control around 66% of patients. And by using 3 drugs at a low dose as a starting point, you will be able to control far more patients. I know this is completely different from current guidelines, both the intensive blood pressure lowering targets and also this concept, but that's exactly what we're trying to do with our research at the George, challenging the guidelines and challenging the way we treat high blood pressure. Some other folks and other colleagues from the George conducted trials testing this strategy of starting therapy with either a triple pill combination therapy of either with a low dose triple combination therapy or a low dose quadrupill with 4 components. And as you can see in both 24 weeks or 12 months, you are able to better control patients. So the single pill combination strategy is a way to improve adherence and to put patients on target quicker, but we need a bit more than that. And this needs to be combined by early titration visits. There is a systematic review recently published showing that around 80% of the pharmacological effect that you see in patients with high blood pressure is achieved by 2 weeks. So if in 2 weeks your patient is not controlled, it's very unlikely that he will be controlled at the longer term. So you need to up titrate early. You don't need to wait. And that's exactly fighting back therapeutic inertia. And also we need to remember that blood pressure levels fluctuate considerably in all individuals. So if you want to achieve 80% of patients with a target of less than 140 per 90, you need to target for a mean blood pressure of 135 per 85, for example, because you need to consider a standard deviation of around between 8 and 10 millimeters of mercury. It's the same thing that we're doing in our trials. In the optimal trial, we're targeting less than 120. To achieve that, you need to target less than 115. And then most patients will get to target, especially if you use single combination therapies using 3 different classes. So that's exactly a part of what we're trying to do at the George, is conducting further trials, combining the single pill combination approach. We have our own through George Medicine's single pill combination of telmisartan, amlodipine, and indapamide. Indapamide is also, as you know, a thiazide-like diuretic. And we have both quarter dose, half dose, and standard dose versions. So the idea in trials that are being currently designed and conducted is you'll probably be able to control around 80% of patients up to 3 months, and probably even within 1 month. That's what preliminary data suggests. So instead of starting patients with monotherapy, you will start with one pill, a single pill combination of 3 classes at a quarter dose or a half dose, depending on the baseline blood pressure levels and whether patients are treated or untreated. And you see patients in 2 weeks. If they're not controlled, you up escalate to the next dose. If they're not controlled in the other 2 weeks, you up escalate again to the next dose. And by doing so, you could, in a pragmatic way and quickly, without increasing, once again, side effects, potentially control over, once again, 80% of the patients quite quickly. And hopefully this will translate into lower risk of major cardiovascular events. So in conclusion, as I mentioned, there is a log linear relationship between blood pressure levels and risk of major cardiovascular events. The SPRINT trial provides solid evidence that a lower blood pressure target translates into lower risk of major cardiovascular events. And we have the ongoing optimal diabetes and optimal stroke trials that could potentially provide further insights into these populations. And we truly believe, and we're doing trials testing that use of low dose or ultra low dose single pill combinations as first line therapy, combined with an accelerated and easy to implement treatment algorithm, has the potential to achieve more than 80% blood pressure control in just a few weeks. Thank you very much for your attention.